David Wallace with PV Reporter.
Rich Stone from Dana-Farber Cancer Institute in Boston, Massachusetts.
Nice to see you, Rich. I'm glad you could make it here today at ASH 2014 in San Francisco. I understand you are part of developing the Rapid Heme Panel. And what I would like to find out, tell us a little bit more about the Rapid Heme Panel and some of the benefits for patients and physicians.
Well, the Rapid Heme Panel is a relatively unique way to rapidly assess genetic abnormalities in patients with hematologic malignancies, including AML, ALL, and myeloproliferative neoplasms. And I don't take much of the credit for it, although I certainly I'm using it quite a bit. Dr. Coleman Lindsley, who just gave an excellent presentation about the ontogeny of AML, in cooperation with Dr. Neil Lindeman, who heads the Center for Advanced Molecular Diagnostics, and two molecular pathologists, Dr. Michael Kluk and Dr. Frank Kuo. The three of those guys, with Dr. Lindeman's guidance, have set up this Illumina-based sequencing platform that enables us to take blood or bone marrow from a patient with one of the aforementioned diseases, myeloid neoplasms or lymphoid neoplasms, and with just a few days get the answer as to whether any of a 96 gene panel set have mutations. These are focused on known mutations. This is not discovery, this is a clinical test.
Okay.
But it can be very advantageous in all the patient subgroups I mentioned, because we can tell if the patient, in the case of a myeloproliferative patient, we can tell whether they have a JAK2 mutation, a calreticulin mutation, or other mutations that might be pathophysiologically, in fact, in some cases, clinically relevant. So the rapidity and the thoroughness of this test are really what sets it apart from other tests right now.
Okay, excellent. You kind of answered my next question, but I'll toss it in there anyway and see if there's any others. So I was going to ask you, what were some of the mutations you screened for in NPNs? You gave me several. Were there any others?
I think the two key ones right now are JAK2 V617F and calreticulin.
Okay.
But some of our myeloproliferative neoplasm patients have other mutations that were more typical of MDS or secondary AML, like mutations in the cohesin complex, mutations in the spliceosome complex, or epigenetic mutations that might help us think of whether their disease has evolved or is evolving into other disease subsets.
And is it possible that by looking at this Rapid Heme Panel, is that able to replace some of the information, say maybe a bone marrow may not be necessary, a bone marrow biopsy, or does it need to be done in conjunction with it?
That's a good question. I mean, to diagnose polycythemia vera, for example, you really need a high crit and a JAK2 V617F mutation.
Right.
So whether every patient that might have PV who meets those diagnostic criteria needs a bone marrow is a matter of some debate.
Yes.
There may be additional features which one can look at, like early fibrosis, that might be somewhat helpful clinically.
Okay.
But to make the diagnosis, you really could, even now, you could make the diagnosis and begin therapeutic plan without a bone marrow. Again, to rule out other entities, it's probably not a bad idea to do one, but it's a matter of debate.
Okay, and as a patient, I know I'm not crazy about having one done unless I feel that, and my physician feels that it's necessary, so yeah.
I think it's a great point. I think right now, most patients with PV get one at diagnosis, but very rarely do they need one down the road unless they stop making red cells and start not producing them and even become anemic.
Right.
Then we would do one to rule out other entities such as myelofibrosis or even, God forbid, acute leukemia.
Okay, and that's a key point. So when there's a change of the blood counts and whatnot is really what kicks off when a need for B&B might be required.
Yeah, actually, yes, and that's another point. At any stage of progression, we would also repeat the Rapid Heme Panel.
Okay.
Because especially in the clinical scenario you just mentioned, where a patient with PV is doing well and they stop doing well or as well, there may be some genetic changes that clue us in it as to what might be going on clinically as well.
Okay.
Or might at least confirm what we think is going on or add to it.
Okay, very good. Let me ask you this, Dr. Stone. What level of detail is provided in the panel report? And as a for instance, a patient may test positive for the JAK2 positive mutation. Will it also show what the allele burden is?
Yes, it does do that because it gives us the allele frequency. The measurement of allele frequency is, I would put that in the research category right now. Many patients are very interested in their allele frequency. There are some researchers who suggest that that might be a hint as to how they're doing. If they go and interfere on their allele frequency, it may drop. Whether that's clearly associated with a better outcome down the road has not been proven, although it's certainly suggestive. So, yeah, that serial rapid heme panels could certainly give us that information.
Okay.
And, you know, so that's where the rapid heme panel, a similar test that we've done, I'm sure, around the country, will enable research to be done more readily.
Okay. That actually led to another one of my questions when you say to be done around the country. Are there plans to roll out this type of test? I've read about similar tests in other institutions.
Yeah, definitely. I think it's going to be replicated widely. I mean, the Brigham and Women's Hospital, where the pathologists reside in the Dana-Farber, which is basically one cancer center across the street where I reside, could make this available widely if patients could send marrow blood, or if their doctors could send the patient's marrow blood to us and we could give them an answer. But I think realistically what's going to happen is that since the technology is not, it's new, but it's not, licensed to us.
Right.
Anybody can do it if they have the wherewithal and the resources to do it.
Okay.
Right now, what happens in practice is that the samples get sent out to a commercial path lab.
Right, like a LabCorp?
Correct.
Okay.
And they'll do some of them do a little frequency, some don't. But you have to ask for specific mutations. The rapid heme panel, for the same cost to the patient and society, gives you 95 genes, which means that we may find some things that we don't know about that might be relevant. We'll find the basic clinical information,
Okay.
but inevitably we'll find some other things at no cost, extra cost to the public, that will be relevant once we do this research. For example, the allelic frequency stuff.
Right, and this just kind of popped in my head off the spur, but is it possible that you can find multiple leukemias or blood cancers on that same panel?
In a given patient?
Yes.
Yeah. We could. I mean, if we find mutations that we don't expect, we might wonder whether there's another hematologic malignancy going on. Although, frankly, I would be, at this stage, I wouldn't want to diagnose anybody with a second cancer just based on the genetics.
Okay.
Since they haven't been validated, I still want the old-fashioned see it with your eyes type of deal.
Okay. Where are you going from here, and what are your plans for the future regarding this test? And
Right. That's a good question. I mean, I think the near-term plans are to send it on all the patients who could benefit, because it is a test that's paid for by their insurance company, and to do retrospective research to see, for example, if patients with high allelic burdens do worse than those with low allelic burdens, to generate some hypothesis which we can look at. I mean, it's no different than the type of research we do now, looking at our patients' charts to see if to take a simple example, to see if a high white count leukemia is a bad prognostic sign. We can add to, I think the genetics gives us a much more objective idea about what's really going on pathophysiologically than the old-fashioned pathology. We still need pathology, but we need to add to that with genetics, just like we added cytogenetics to the way we characterize AML 15 or 20 years ago. We're now going to be adding the genetic tests, and if we do genetic tests on everybody, just like we did cytogenetic tests on everybody, and we made that leap, then we'll be able to do this research and understand the diseases a lot better.
Okay, excellent. Well, I appreciate you giving us an overview of the heme panel, Dr. Stone, and this is David Wallace reporting with PV Reporter from ASH in San Francisco 2014. Thank you, Dr. Stone.
Thank you.